Hello, welcome back. I'm Dr. John. Now let's talk about anemia classification. Anemia is not a disease. It is a sign or symptoms of many diseases. Diagnosis of anemia shouldn't be a problem unless you cannot differentiate relative anemia or diluted anemia from absolute anemia or true anemia, which we have discussed in the recording of relative anemia and relative polycythemia. The reason we classify anemia is to find out the cause of anemia so that the physician can direct the treatment to the underlying causes or mechanisms. So, where do we start from? MCV, which is a very important index to differentiate and classify different types of anemia. Less than 80 femtoliters is known as microcytic. The red cells are smaller, the central pallor is enlarged, and MCHC is less than 32 grams per deciliter, which is known as hypochromic. Here are the four most common causes of microcytosis associated with hypochromic due to reduced hemoglobin synthesis, including sideroblastic anemia, in which iron cannot be incorporated properly, iron deficiency anemia, in which iron is not available, anemia of chronic inflammation, in which iron is deficient in bloodstream with plenty of iron storage, thalassemia, in which the mutant globin genes cause decreased globin chain production. Microcytic anemia is when MCV is bigger than 100 femtoliter and can be further classified into two subgroups, non-megaloblastic or megaloblastic. Megaloblastic means DNA synthesis is inhibited. Non-megaloblastic means DNA synthesis is not inhibited. Aplastic anemia develops when bone marrow or hematopoietic stem cells are damaged. Not all aplastic anemia are macrocytic. Some are normocytic, as shown here. It depends on how the bone marrow is being damaged. If by DNA methylation agent, the aplastic anemia is macrocytic, as the red cell cannot divide properly. If by infection, aplastic anemia is normocytic. Microcytic anemia caused by chronic liver disease is non-megaloblastic. Red cells are getting bigger because of deposition of cholesterol or phospholipids on the red cell membrane. Alcohol can damage the bone marrow directly, causing macrocytic anemia. Macrocytic megaloblastic anemia are seen in vitamin B12 or folate deficiency or some drugs, and the anemia seen in myelodysplasia, erythroleukemia are megaloblastic as well. In all of them, DNA synthesis is messed up, making them megaloblastic. The red cells getting bigger because of a proportional development between nucleus and cytoplasm. The drugs such as anti-cancer or anti-immune drugs are very common cause of megaloblastic anemia in the clinic. Normocytic anemia is when MCV is within the normal reference range, that is between 80 and 100 femtoliter, including hemolytic anemia. Notice, in this type, reticulocyte count is increased. Aplastic anemia due to renal disease because erythropoietin level is low. Myelophysic means hematopoietic tissue of bone marrow replaced by tumor cell fibers or granulomas. Obviously, anemia develops in those cases. Infection, for example, pivovirus B19, can cause aplastic crisis in sickle cell disease patients, or chronic inflammation in which retic count is normal or decreased. As you can see, that retic count is another very important index in anemia differentiation. Hemolytic anemia can be further divided into two subgroups: intrinsic, meaning the red cell itself has a defect and therefore rupture easily. Such defects could lie in the membrane, hemoglobin, or the enzymes inside the red cell. Extrinsic meaning something else rather than red cell itself causes the rupture, such as some antibodies can attack red cells. For example, autoimmune hemolytic anemia is a group of diseases that can be caused by warm or cold antibodies. Is it a good time to review blood bank? See, this is when hematology and blood bank come across each other. It is a good idea to pull out both textbooks and study or review them together side by side. Non-immune factors can damage red cell as well. If those factors are in the small blood vessels, we call that microangiopathic hemolytic anemia, such as hemolytic uremic syndrome, DIC, or TPP, in which the fibrin mesh of small blood clots cut the red cells to schistocytes. If the red cells are damaged in the large blood vessels, for example, by prosthetic or calcified heart valves, that is called a microangiopathic hemolytic anemia. Hemolytic anemia can develop in second or third degree burn patients within 24 hours due to damage of skeletal proteins of red cells by heat. Some toxins of microorganisms and venoms can also damage skeletal proteins of the red cells, causing hemolytic anemia. Have you noticed that the anemia caused by chronic inflammation can be either microcytic or normocytic? It is the most common type of anemia among hospitalized patients. What is the most common cause of folate deficiency? Diet. What about vitamin B12 deficiency? Autoimmune disease. Which one? Pernicious anemia. If we dig deeper of the causes listed in this figure, we have to talk about at least a half volume of internal medicine textbook, but we can always find a simple way to look at things. All microcytic anemia share one thing in common, that is a problem in making hemoglobin. What about a macrocytic anemia? Red cell maturation. The normocytic anemia is the most complicated and has very diversified causes. Now, let's move on to the next important index that we use in the lab to differentiate anemia, that is RDW. RDW increases in early nutrition deficiency, including iron, folate, or vitamin B12 deficiency. In the early stage of those deficiencies, RDW increases earlier than other parameters. When some cells get enough nutrients, while others do not get enough nutrients, some are smaller, others are normal, as in iron deficiency, or some are bigger while others are normal, as in folate or vitamin B12 deficiency. Let's study this table a little bit. In the group of microcytic anemia, anemia caused by iron deficiency or sickle cell beta thalassemia have high RDW, which means unequal size of red cells, whereas RDW is normal in heterozygous thalassemia, anemia of chronic inflammation, and hemoglobin E disease or trait. In macrocytic anemia, increased RDW is seen in anemia caused by folate or vitamin B12 deficiency, MDS, chemotherapy, or cold agglutinin disease, but is normal in aplastic anemia or alcoholism. Notice RDW can be high or normal in chronic liver disease. Therefore, RDW helps to narrow down the differentiation of anemia. Here is my take-home question for you. What is the difference between RDW-SD and RDW-CV? Now it is the quiz time. Have you got all questions right? If yes, congratulations. If not, not bad, as now you know where to spend more time. And I thank you very much for your attention.